Hello, this is Mike. Hello?
Mike, can you speak a little louder?
I didn't know if I was live yet or not. I didn't know what was going on.
Yes, you are. And we see your
we
slides
ready to
here,
begin?
so you can go right ahead.
And can be heard fine?
Yes.
Great, thank you. Let's turn this up a little bit. That might help something. Hello to everybody. Thank you for waiting. My name is Mike Palladini. I'll be presenting this information to you today on SBIRT, Knowing About Substances Makes a Better Intervention. I'll just share with you that this presentation was originally entitled Medical Aspects and Effects of Major Drugs of Abuse, as we wanted to get across the identification of the drugs that we'll be talking about that you need to be able to identify, as well as some of the short-term and long-term physiological and psychological effects. You'll see my name on the title slide, as well as a Mr. Ken Dickinson, who I have collaborated with several times. And this presentation and these slides were originally with Ken and were given to me to take care of this presentation, which I adjusted somewhat. And just to share with you, I thought it was a good idea to make a run-through with these slides with a outpatient group of individuals in recovery to see what their take on it was, and just to get somewhat of an idea of their understanding of this material. And we got through some of it, but there were a multitude of questions from them, and there was some understanding, but just to share with you and to try to get across the intention of this presentation in gaining knowledge and feeling more confident in dealing with all the different substances that are out there. There was some understanding among the group. I'd say there's always going to be about 20% of the attendees, or a group of people like in recovery like that, that are going to have a better knowledge of the substances than the rest. But there's also a large amount of misinformation out there. So there could be some understanding among the clientele of what these substances are, but there's also some clarification that needs to be made. So with that in mind, once you get a better handle and more confidence in what these substances are and identifying them and what they do, you will have the upper hand and a better knowledge base than what's being gained personally and on the street, I guess you could put it, from the client. So I had to clarify quite a bit of information while we went through some of this presentation last night. So I thought it was a good primer for doing this for you, and a good way to set the stage in proceeding. So if we move on a bit here, one second please. I'm operating a work monitor. So there we go. So if we're able to classify all the drugs that we're going to be looking at, and that's how these types of presentations, and that's how most of the substances that we're going to see when we're talking about addiction are going to fall into one of these four major categories, and then there's always a few we can throw into the miscellaneous category. So if you consider, and all the talks I've done in the literature I've helped develop, and the publications I've had, we can always look at the substances as falling into one of these categories. So we're going to look at stimulants or psychostimulants worded here, or uppers. Opioids, which are a depressant or a downer, if we're going to be talking about how basically we're affected. Sedative hypnotics, depressants. Alcohol falls into that category. Or hallucinogens and dissociatives. Marijuana, the most common now, falls into the category of a hallucinogen. And the miscellaneous category is going to include some inhalants, abused steroids, and a couple of other medications and substances. So can always consider substances of abuse as to falling into 4 major categories: stimulants, opiates, sedative hypnotics, and hallucinogens. And these are categorized by their chemistry or their pharmacology, their source, their natural source, their man-made source, all based on a specific chemical configuration. And as we go through some of these, we'll refer to that, and that is why, based on their effect and their chemistry, they fall into one of the 4 categories. Some principles to consider when we're talking about the effects of these substances. The major therapeutic or desired effect is always going to be within the central nervous system, and that includes the brain and the spinal cord. The target area are areas in the brain where neurochemicals reside, where they have their largest effect, be it a pain-relieving drug as an opiate, a stimulant drug, say cocaine or an amphetamine, a sleeping pill such as a benzodiazepine, marijuana as a hallucinogen. All these desired effects are within the brain as well as in the spinal column, where there are numerous receptors as well. You're also going to have effects on what's called the peripheral nervous system outside of the central nervous system. Unfortunately, if we target a receptor or an area of the brain where we need a desired effect, there's a lot of networking and communication within our brain and our nervous system that corresponds to peripheral nervous system action. And that is where a lot of the undesired or side effects or long-term adverse effects are going to occur, because of the stimulation within the central nervous system corresponds to stimulation in the peripheral nervous system. And that peripheral nervous system can be broken down into 2 separate systems, the autonomic and the somatic. The autonomic nervous system, and I apologize this slide doesn't break that down even further, is broken down into 2 groups of the sympathetic and parasympathetic systems. And you can look at those 2 and consider the sympathetic as the fight or flight response system, and the parasympathetic as the rest and digest nervous system. So any stimulation of the sympathetic nervous system is going to cue our bodies and our nervous system to be in that fight or flight mode, where heart rate is increased, blood is pumped to our musculature to promote that flight capability. The eyes are going to dilate to increase peripheral vision, and so forth. And we'll look at some of the characteristics of that when we discuss which chemicals, which drugs affect that. Conversely, in balance with that is the parasympathetic or rest or digest system, which brings that all back down and allows us to maintain a homeostasis state. So we're always having to consider the effects of drugs on the peripheral or nervous system that's beyond our control as well. There's the somatic nervous system there, which is the voluntary or controlled nervous system, which allows us to control our musculature, our skeletal musculature. So voluntary movements are within the domain of the somatic nervous system. Again, peripherally, we're talking about, in general, heart rate, digestion, respiratory rate, salivation, pupil dilation, organ involvement with bladder control, blood flow to muscles. All of that is being affected when substances target the central nervous system. We're going to get these effects as well. And those are the effects of the autonomic nervous system that are going to be manifested, that are going to be cues as to what substance the nervous system, the central nervous system, is under the effect of. Let's look at some overall effects and overall considerations when we're talking about substance use. There's going to be some obvious physical changes, physical long-term effects that are dependent on a particular route of administration. Now, we've got the powder drugs listed here: cocaine, heroin, methamphetamine, etc. These drugs are normally produced and dispensed as a powder, and they can be used either intranasally or dissolved and used intravenously. Prescription drugs, RX drugs, Vicodin, Adderall, Ritalin, any type of benzo, any so-called pill that is sold as a prescription drug for oral use purposes can also be ground up, dissolved into a liquid, usually water, and heated and used intravenously. Certainly not meant to do that, but if that is done, you run the risk of all of these types of situations we're talking about. Abscesses at the injection site, the possibility of an embolism when material that is not meant to be injected is injected into the vein. Hepatitis B and C, transmitted bloodborne viruses that are transmitted via the intravenous route. HIV and AIDS diagnoses. Septicemia, where an infection becomes septic and throughout the system. Endocarditis, where the emboli or other bacterial ends up affecting the heart lining, and you get a inflammation of the heart lining. All of these situations, all of these conditions can be attributed to IV drug use. So as someone doing a brief intervention may see Hep C, Hep B, HIV, maybe an endocarditis diagnosis historically, where that may be a quick cue for one to realize that this person is very likely an intravenous drug user. Visible abscesses on the arms, track marks, that types of thing are going to be obvious cues to intravenous drug use. If someone is using these same drugs that are in a powdered form and not injecting and dissolving into a fluid, but simply snorting the powder, you are going to get the types of effects listed here. Easily susceptible to a nose or sinus bleeding, recurrent sinus infections, a diagnosis of a deviated septum, or maybe the appearance of one that has not been diagnosed yet. These types of situations may lead one to believe that there is a large amount of a drug insufflating or snorting going on. Someone complaining of nosebleeds all the time, spontaneous nosebleeds in your presence, obvious signs. And smoking is listed here, where these drugs can be smoked. Not all of them, but heroin, methamphetamine can be used in that manner. And then I think it's quite obvious that smoking can lead to symptoms of bronchitis, diagnosis of pneumonia, COPD, and even advanced can be cancer. And that goes with smoking any type of material, nicotine, as well as some of the other drugs that are involved. Crack cocaine is a large one. Now, this presentation is broken down to discuss the categories that we mentioned up front, stimulants, opioids, sedative hypnotics, and hallucinogens, categorically. So the first one that is presented here are the psychostimulants. Basically stimulants, psychostimulants meaning that they are stimulating the central nervous system and the neurochemicals involved there. The psychostimulants can be broken down to these 6 specific substances. Amphetamine.
One more thing.
Pardon me? We're good? Okay.
Go ahead, Mike. Sorry, I'll mute the other person.
That's fine, thank you. Amphetamines, a prescription medication for mainly ADHD. Adderall listed there. There are street or illicit sources of amphetamine, usually methamphetamine, speed, crystal, referring to methamphetamine. There are congeners or chemical analogs, they're called, of amphetamine, and that is what Ritalin is as a prescription ADHD medication. So Ritalin is very closely related to amphetamines in chemistry, and you're going to get the same types of effects. We were discussing that last night in our group, and it reminded me of something I've seen quoted several times, that if you took Ritalin and ground it up and dissolved it, and a cocaine injector was given Ritalin instead, they cannot tell the difference. And Ritalin has a quotation around it that calls it the pharmaceutical equivalent, injectable pharmaceutical equivalent of cocaine. So there's really not a whole lot of difference in injecting cocaine and injecting Ritalin. So it has a high value to a psychostimulant abuser in that respect. So it can really be lumped in for our purposes as an amphetamine. Slightly different chemically, but it falls in that category. Cocaine, on the other hand, is the natural substance that can be found, the alkaloid cocaine, small concentrations in the leaves, chew on the leaves, mild stimulation. But if it's concentrated and extracted to the extent that it has been for the past couple hundred years, you get cocaine hydrochloride, which is the powder, which is normally snorted, can be dissolved and injected as well. It can also be converted back to a base form, and that is when you have crack cocaine, where one uses sodium hydroxide to form the crack, or you can use ether and you get what's called the free base. What that does is that just gives a better form for utilizing it as one wishes to for administration. The HCl, or the hydrochloride, is best for snorting. The crack and the free base are better for smoking based on the way they're chemically produced. Again, a stimulant effect similar to amphetamine. The cathinones are getting a lot more attention these days. I'm going to be working on a presentation with another gentleman here in the spring to deliver to a conference, so I'll be able to share better information after that. But currently, the bath salts have gotten a lot of attention and a lot of need to determine what these are and the trends involved with them. They are a cathinone-based chemical. Cathinones come from the khat plant, K-H-A-T, which grows in East Africa. The khat plant, the cathinone within the khat plant is similar in nature to the cocaine in the coca plant, where you've got a mild stimulant within a natural plant source. But if it's chemically extracted and chemically changed, you get other chemicals. In this case, the bath salts, or the MDPV. If you look that up, you'll find methylene dioxypyrovalerone, which is a chemical analog of the caffeinone, as is mephedrone, which creates a highly charged psychostimulant effect, as well as some hallucinogenic properties as well. But the caffeinones, aka bath salts, fall under the stimulant category. And the effects of them are kind of in line with what we'll see with the other stimulants, only to an extremely exaggerated state because it is a much more potent chemical. People are stimulated to the point of being hallucinatory. So they're not truly on a hallucinogen, but they are really overly stimulated by this chemical. And then just to mention, caffeine and nicotine as our stimulants. Coffee, tea, most people use those to get through their day. Cigarettes and cigars for the nicotine. The only concern there, I would say, for our purposes, and in a brief evaluation, would be perhaps somebody's use of OTC meds unduly, or really starting to use energy drinks to an extreme. You're getting a lot of caffeine, a lot of other chemicals in there that are meant to provide energy, and I don't know where the formulation of these is going to stop. They keep getting more concentrated, more potent. The small sizes that you can keep in your pocket, 5-hour energy drink, is sold now as, hey, this is what you need to do. I get my energy. Here you go. Here's yours. We pass it around. We suck our 5-hour energy drink instead of sitting around and enjoying a cup of coffee. We can get several cups in just by squirting it down our throat quickly. So the energy drinks are something to keep an eye on. People will admit to using them. They don't see an issue with it, but it's something that might be taken into account if someone especially had a past history of abusing other stimulants. So they're really mildly hitting those responses that the stimulants did, but in an aspect that they think may be okay now, but might want to keep an eye on their energy drink consumption. I threw a few pictures in here. The other presentation did not have them, just so we can get a nice visual. This tablet up top here, the white tablet, is a 5 milligram Desoxyn, D-E-S-O-X-Y-N tablet, which historically, going back maybe 50-plus years, was the amphetamine, the diet pill of the 50s and 60s, and Desoxyn was the brand name for methamphetamine. So methamphetamine has been around for quite a while as a usable amphetamine. It fell out of favor when the street formulation of it, which was then in a powder or a crystalline form, became available. So you're not going to see a whole lot of doctors prescribing Desoxyn for somebody who needs to lose a few pounds. There's other options available nowadays, but it is still on the formulary of a manufacturer, and it is still produced, although I'm not sure how much of it they're selling these days. Over here is an Adderall XR tablet. That's a prescription psychostimulant, mainly used for ADHD as an alternative to Ritalin. So you'll have Adderall, you'll have Concerta, you'll have Ritalin. A lot of young adults maintain their prescription for a stimulant for ADHD that may have been diagnosed years prior, and depending on how they were monitored and how that use was taken care of, it may have been unnecessary after a certain amount of years, or it may be something that has never truly been monitored, and they're continuing to take it and taking more and more of it into their early 20s, continuing to get that prescription, and that's the source of diversion and where these pills end up in social circles. The tablets, the capsules with the tiny beads there can be opened up, crushed up, snorted, dissolved, injected. The options are there, and that's what's unfortunate is if these possibilities exist, that's what you're going to start seeing, people really taking it to the limit and seeing what they can do with these types of formulations. This picture here are just some lines of powdered cocaine as opposed to the crack pipe or the crack cocaine there being smoked. So here you have powder that can be snorted, lending to some of those nasal effects we saw, or smoking cocaine here, which could lead to some of the bronchitis, pneumonia type effects that we were talking about. There is a picture of what's called Ivory Soft concentrated bath salts novelty. This was one package that, one product that was around a year or so ago until the feds and some state authorities really got a handle on what this stuff was, and that is how it was being sold and packaged. The other side of this is not for human consumption. So there's a visual for you as to what some of these stimulants we're talking about, how they look, and the various forms they could take. If you want to look at the pharmacology of how these drugs are working within our central nervous system, and again then, as we mentioned up front, within our peripheral nervous system, they are the body's own energy chemicals. They are affecting those certain neurotransmitters, which are, DA is dopamine, epinephrine, norepinephrine, 5-HT for serotonin, and choline mentioned there. Really, the target neurochemical for stimulant use is dopamine, that part of the midbrain where dopamine is highly concentrated and produced, considered the reward neurochemical. So psychostimulant use produces a strong reward response within our brains that translates into a wanting of more. Epinephrine being stimulated as well, and epinephrine then is the fight or flight, as well as norepinephrine neurochemical, which we talked about earlier. So you start stimulating a lot of epinephrine, norepinephrine, and you get the dilation of the pupils, the heart rate going up, the tense muscles, the blood flow, the heart needing to pump more blood peripherally, and we're all in that fight or flight mode or position at that point. And if you consider what, and this was something we talked about last night, and I don't know about the crowd that's listening now, but there were a lot of people in the group that knew what I was talking about when you say that the person who's truly abusing cocaine and using quite a bit of it always seems to be in that particular mode of existence. They're always on edge, so to speak, as if something was about to happen. Their heart's racing. Their pupils are huge. They hear things. They're waiting for something. They are on edge because that is what those neurochemicals are supposed to do when needed, when stimulated by an external stimuli that prompts it. But now we are creating a false sense of the fight or flight situation by dumping dopamine, epinephrine, norepinephrine into our systems and putting ourselves in that situation. So they are the body's own energy chemicals, but we are supplanting them with overabundance of a external substance. And the intention of this presentation is not to get into the brain neurochemistry to get in depth with there, but that is where it is all rooted, and from there are the effects that we are going to discuss and look at. So initial effects of stimulant use. Someone's snorting cocaine or taking an amphetamine capsule that they were prescribed or took an extra one or borrowed one from somebody. The initial effects, which kick in shortly after administration, if it's taken orally, immediately if smoked or injected, maybe 30 minutes or so if snorted. A feeling of increased energy, increased heart rate and blood pressure, rapid breathing and hyperreflexes, overextension, not a great control on our reflexes, restlessness and excessive talking, hypersensitivity, and that could be to any type of tactile or audio type of stimulation. Just everything seems to be amplified. They're hypersensitive. And this all will form a picture for you. If you think of a stimulant, think of if you're a coffee drinker, if you normally drink a cup of coffee one day, but you happen to be out with some friends and you end up drinking 5 cups before you actually got up and left to where you needed to go, that's the feeling amplified. It's just everything is go, go, go. We are really on with the stimulants. The heart is pumping, the blood's flowing, breathing might be slightly elevated, find yourself talking more than you used to, and so forth. More initial effects, like we mentioned with the norepinephrine fight or flight symptoms, dilated pupils. One of the first things I believe that state troopers look for when they're, of course, they're trained to make an immediate assessment looking at somebody's eyes and the reflexes with the eyes. The stimulants give us those huge pupils, dilated pupils. Loss of appetite or thirst. The loss of appetite is the key neurochemically with the norepinephrine and its effect on our digestive tract, what led to these drugs being the diet pills of past. I mean, they are still somewhat utilized that way, but we have learned that even the milder over-the-counter type strengths of these drugs are ultimately not good for us and cause some negative consequences with our cardiac functions, with our heart rate. So they're not really the drug of choice for dieting anymore, but we found that out the hard way. A lot of people were taking pretty strong amphetamines through the 60s and 70s as a diet aid and enjoyed the side effect of increased energy as well. So they were kind of hesitant to let go of them even when the diet was not necessary anymore. And then the lack of pleasure reward that would be experienced when they tried to get off of them led to tolerance, led to people wanting to maintain these. So a lot of stimulant dependence grew out of that. A pleasurable euphoria at the right dose that someone may determine that they can feel that euphoria from those neurochemicals being flooded out into their CNS, especially in the spinal cord. Overconfidence, grandiosity. Someone is larger than life. They're always on. They're up all the time. They are going to accomplish 20 things today when they normally don't do anything. The stimulants give them that confidence, that feeling that I can do this. It may be a momentary feeling that they don't truly recall much later, but it lends into that as well. Chronic and high dose effects. Now we're moving on to someone using quite a bit of medication. High dose usually goes hand in hand with chronic use, as the whole idea of tolerance usually develops with most of the substances that are considered drugs of abuse. So higher doses are needed. And when higher doses are ingested over time, then we get more and more involvement with the peripheral nervous system and larger degrees of the side effects that are a nuisance and overall destructive in the end. Paranoia, I think that should be 2 words there, may be severe. Aggression, hypersexuality, insomnia. Insomnia in the fact that these are stimulants and the initial effect may linger for a while, but the chronic effects are going to maintain their presence in the brain where the sleep cycle is disrupted. We're still stimulated to the point where the heart rate does not return to where it needs to be. So we're feeling insomnia. The patient cannot get a good night's sleep, can't get into a rhythm anymore. Insomnia, I'm sure people who are listening, if they've done any types of evaluations and assessments, the sleep pattern and sleep health is always important to key in on how somebody's doing. And it may be lack of sleep due to certain factors of withdrawal or through an early recovery, which is expected, hence the large amount of prescribing that's done to people in recovery to help them get into a sleep cycle. If they're not being medicated for that particular condition, most physicians will look at it as something that needs to happen, and the right medication has to be chosen depending on their substance abuse history. A compulsive fascination with useless, repetitive tasks. That's a great line. You know, playing with a button, pulling on their hair, that kind of nervous energy. If anybody can picture somebody they've seen that is involved with something like that, that is almost like a OCD type of maneuver that someone is using to cope with the way they're feeling. Anorexia, again, we've talked about appetite suppression. If someone was prone to any issues with their diet, then anorexia may develop very easily if they're in the if they're abusing these stimulants. Hyperthermia. Hyperthermia to the degree that they are using a high dose of a particular amphetamine or methamphetamine, and the mechanism in our brain, in our central nervous system that controls our internal body temperature is thwarted, where it is not working as well as it should be, and the internal body temperature can raise beyond our recognition. And a lot of times that may occur with an increased amount of activity where people are dancing a lot at so-called raves, or running around a lot, or just not aware of, you know, how hot they truly are becoming, and not hydrating themselves properly. So it could reach an extent where the brain actually sort of shuts down because the environment it's in is so warm and so hot, and people have had fatal results because of that. So it's important that hydration occurs there. And these are some that would be a high dose, acute effect. I'm not quite sure someone undergoing an SBIRT evaluation would show up in a severe case of hyperthermia, but if it's something that is noted or historically present, again, it's a cue that stimulant, high-dose stimulant use was in the past. And that's another thing to consider when you're looking at drug use history and some of the effects of these drugs. You know, always consider right here what we're talking about with dosing. And if you grasp the idea of tolerance and how long somebody may be using, and again, it's always going to be subject to individual variation, but for the most part, time and chronic use is going to reflect in high dosages, simply because of the tolerance that these drugs lend and the need for more to obtain the same effect. So that's always something to keep into consideration. If if their drug use history has been, yeah, I've been using, you know, crack cocaine for 7 years, towards the end of that, they are going to be using quite a bit of it, and they will have most likely experienced some of these high-dose effects that we're talking about. The formication or tactile hallucinations, I've seen that in print as, quote, the cocaine bugs, unquote, where people have felt bugs or something on them, and they're convinced that something is on them. That is a tactile hallucination simply because of an overstimulation of nerve endings on the skin. Erectile dysfunction has to do with chronic blood flow to the vital areas. Depression, and this should be in bold print, and that is probably something that needs to be considered for any stimulant, any client who has had a stimulant abuse history. The nature of what the stimulants can do in our central nervous system by the overabundance of neurochemicals that with dopamine and norepinephrine and serotonin that relate to this extremely high pleasurable situation. Well, when the drug is taken away, then those levels dip down to well below a baseline type of level. And if you do that chronically, they're going to go down there, and those levels are going to stay down there. And I like to illustrate it as being something that is akin to a clinical depression, where the neurochemical levels would reflect somebody who's clinically depressed regardless of any drug use history. So there is not just a acute feeling where I'm kind of down because I blew $500 on crack cocaine last night. This is a chronic situation or condition where the neurochemicals responsible for mood elevation and stabilization have been depleted to the point where it's not possible for this individual to get out of it. So they are clinically depressed. And if someone is not honest with a physician, or they start seeing a psychiatrist or so and are diagnosed as depressed, and the habit of using stimulants or abusing stimulants does not come to light, then they'll be classified as depressed, and they could gain that label and diagnosis at a younger age because they don't want to express that they've been using stimulants for a long time. So here now they could still be using stimulants, but now they've got an antidepressant or two prescribed on a daily basis. So they have depression, and then we enter into the co-occurring world where perhaps they are depressed, perhaps they're not. Maybe it's just a situation of abuse of a stimulant. Bold print that, circle that, something that always needs to be considered, obviously, since it has earned itself a place as a co-occurring disorder. But depression is if it's linked to someone who's had ongoing stimulant abuse, something to really key in on and see how they've handled it, what they've taken, how they felt coming off of the stimulants, if they've ever been clean from stimulants, how was their depression. All that can kind of go hand in hand, if you recall, just based on what stimulants do neurochemically. Cognitive impairment, cognitive deficits, that might be a tough one to assess. There could be many factors leading to someone having a cognitive deficit, but bear in mind that high-dose chronic use of some strong stimulants, such as injecting methamphetamine or snorting it, or use of, say, a cathinone or bath salts for a binge period could lead to some cognitive deficits, meaning approaching a dementia-type status where we don't recall things, memory starting to lose, our ability to sit and make a reasonable decision. And I don't do assessments in my work, so I'm not sure. There could be some situations where someone's seeking some help, and they may be in your office shortly after a binge of using something like methadone or MDPV bath salts. So they could be in a state where they are cognitively impaired, and if there's no true indication of something else being at hand, and the bath salts or that type of story comes out where it's a high-dose stimulant, that could be something that needs to be addressed and considered as the cause there. More effects of these high doses or chronic use of stimulants, some severe side effects, as we're calling them here. Persistent anhedonia. I had to define that to my group last night, meaning inability to find joy or reward in anything. And being a group of people in early recovery, and some in a little bit further along, I mean, I think it was unanimous within the crowd that is something that is prevalent not only with stimulants but with opiates and alcohol as well. So that is something that I don't know what value it would be in an evaluation, but that is certainly an effect that would be valuable to a counselor working with someone over time, that, it's not you, it was the effects of the drug. We're going to get you back to the place where you can start enjoying some things, because it's odd to talk to somebody who is unable to gather any joy out of things they used to do, or can't really see the point in trying this activity or that, and that it's good to make them aware of the fact that this could improve, and that's what we're shooting for. Stimulant psychoses, again, that could be maybe some hallucinations from stimulants. Auditory hallucinations are very common with high-dose use of these stimulants. Hearing things, knock at the door, a loud knock at the door, I heard something, all those kind of paranoid-related hallucinations are usually of an auditory nature. Clinical depression, I think I went into that on the last slide. There's a little bit of repetition here. That could be to the point where, hey, we have developed it where it's been diagnosed by a clinician as a clinical depression. Kidney damage, liver damage, stroke, all because of the autonomic nervous system involvement and the overstimulation of kidneys, liver needing to process these toxins continuously, could lead to damage, long-term chronic damage to these major organs. Okay.
Mike,
Yes.
I hate to interrupt you, but we have some questions on this
Certainly.
last section you just went over. I'd like to address those before we go on.
Perfect. Thank you.
Okay, sure. One of them is, why do prescription medications for migraine headache prevention include caffeine?
Yeah, they've traditionally, the manufacturers, that is, put caffeine in a lot of the drugs that were meant for pain relief, and that was kind of twofold. One, mildly, and I don't really think to any substantial effect, that the blood flow would increase because of a slight increase in the heart rate, and then that would deliver the drug to the therapeutic site a little more quickly. If a migraine or any pain sufferer like that wants relief as quickly as possible. And then simply because a small dose of caffeine could make someone feel a little better, a little more stimulated, kick out a few of those dopamine receptor channels and get a little more dopamine flowing, so someone might feel a little better. They're mild doses, but it was always proven that a little caffeine in there made the drug get to the site a little better, as well as feel just a little bit better. And that's mainly why. I mean, you'll see it in Excedrin. They used to put it in with the Fiorcets and Fiorinols with codeine. I'm sorry, with caffeine. Pardon me there. Yeah, it was used for those two purposes that I just said.
Okay. I have a few people who have their hand icons raised, which means that they want to be unmuted. So we'll see how that works. And then after that, I've got, I think, one more question that has a couple parts to it, okay? Just a moment.
Sure.
Hi, I'm unmuting Cheryl. Cheryl, do you have a question? Okay, could you?
No.
No question?
No.
Okay. Your hand icon was raised, so I'll just click that off then. Thank you. Okay, I'll go down to the next one. Okay, Deborah, did you have a question that you wanted to ask the presenter? Okay, I think a lot of these were done by mistake. It's what usually happens, but we'll try this again. Harry, do you have a question for the presenter? No? Okay, I'm taking these icons off. If people really do have questions, they can please just put that icon on again. And let's see, I'm just going to see if there's any more. Okay, it looks like that's it for the hand raising, so I will ask you the other question that somebody wrote out. You see, I see a lot of clients who are using alcohol until intoxication, then using cocaine to get rid of the drunk. So they want you to comment on that. And then also, what do the long-term effects or chronic use of these two drugs together look like?
That's a great question, and only because I had a gentleman who was in our group for a DUI conviction, alcohol, who also had a cocaine use problem, and he told me that he was pulled over and arrested that night under the influence of alcohol because he did not have any cocaine that night. And normally, if he'd have done the cocaine too, he would have been in much better condition and would not have appeared and would have not have been as sloppy as a drunk as he was that night. So there may be some truth to the fact that if someone is using cocaine a lot and it's something that they've kind of gotten a bit of a tolerance to and used to it, that it can help them to an extent, especially overcome the depressant effects of alcohol in the short run. So it may be something that this particular person's question is addressing for someone who is drinking for several hours and needs some type of a lift, as we might say, to get over the depressant effects that the alcohol can start to have. And again, that's an individual thing where somebody may not have as much tolerance to alcohol. Someone may have more. The cocaine may have no effect at all on a particular person. On another, if depending on how much of it they're using, it might. So I guess the answer to that question is that is entirely possible, that what they're stating could occur, that the cocaine use could assist them in getting over the drunken feeling of alcohol. Definitely not something that you want to give any credence to. And then, of course, if you're mixing cocaine and alcohol a lot, if you look something up online called coca-ethylene, if someone's mixing the two chemicals, cocaine and alcohol, for a long time, there's this metabolite chemical, coca-ethylene, tends to build up in the liver and can be destructive. I mean, alcohol is destructive enough to the liver over time, causing cirrhosis. Cocaine, as we saw, long-term high-dose use can lend to some liver damage, but the two combined in forming coca-ethylene can lead to a really trumped-up version of that. It can really expedite some damage to the liver, and that's been something that's been known and documented for a while. So it's not a good combination if you're looking at it from the perspective of your liver, regardless of what people say they may be experiencing together, the way they may counteract each other. The speedballs of the past, cocaine and heroin mixed together. A lot of heroin users doing it separately, liking to smoke crack after dosing with heroin. Those types of polar effects that kind of shift gears for a person in their brain and give them a unique kind of a buzz, if we could say it that way. Those types of habits you're going to see people experimenting with. They may not seem to go together, but for a particular individual, that may not matter. It may be something that they find pleasurable. So it's not out of the question at all, to get back to our question, to see alcohol use and cocaine use as advantageous for somebody, but definitely something that I would, if you see a history of that, that's something that, when's the last time you had a liver enzyme test? That might be something to recommend that we order. I don't know the extent of some of our audience here of what their practice is, but it could be something that that you could simply order for somebody right then. Let's see what kind of condition your liver's in. I mean, when I see long-term substance use of any of these kind of substances, we're talking about, a liver function test should be something that's pretty much standard with admissions to any kind of inpatient or even intensive outpatient if we're talking about long-term drug use. Thank you.
Okay. I'm getting quite a lot of questions here, so I'll try to get through.
You know what, and Chris, may I add that it's 3 o'clock, and I believe we're supposed to go till 3:30. The presentation continues with some of the methamphetamine-specific discussion.
Okay.
And then it goes into opiates and sedatives and alcohol, which are pretty much a section of their own, because we're going to be shifting gears and talking about depressants for the most part. So if we could answer some questions, that'd be great. And while we could get through the methamphetamine and stimulant effects, I think that would be a good stopping point for this first section.
Okay, that's great. I will hold these questions until you get done with the next session, and we'll handle it that way.
Or we could certainly answer some questions right now. I was referring to. That'd be fine.
Oh, I see. Okay. Building on the mixture of alcohol and cocaine, I work with clients in a methadone clinic, and they will use cocaine to sort of pull the methadone out of their system so they are able to get high using opiates. Again, what specifics would I use to explain the dangers of this to my clients?
The question was that methadone clients are using cocaine to... building on, I work with clients in a methadone clinic, and they are using cocaine to pull the methadone out of their system so they are able to get high using opiates. Okay. Well, I don't know of any evidence to back that practice up. I mean, they may certainly feel that that's working. One, if you can get back down to basics on that, if you've got someone in a methadone program and they're still wanting to use opiates and they're using an additional stimulant substance to use their true drug of choice, it doesn't sound like they're making much progress in that program at all. Not only do we need to discuss the dangers of cocaine in and of itself, that we've got a long-acting opiate in our system, which we'll talk about during the next session, in methadone, and we're adding more opiate to that, which can lead to some severe complications. And then you're adding cocaine, a stimulant, in there, where I would, if we really needed to discuss the true dangers of that, I would lead to the cardiac and the pulmonary relationship there, where we're really taxing our heart in this manner. And if it would lead to a point where we are using opiates on top of our methadone in our system, there's a real chance of a fatal respiratory depression overdose. And the fact that we have taxed our heart by using cocaine chronically now, there's a better chance now that our cardiac system is not going to be able to compensate and supply blood to where it needs to be during this respiratory depression episode. It's just, not to speak medically, because those aren't my credentials, but from what I can surmise of all that situation, that is something that, regardless of the cocaine, the opiates on top of the methadone are the true danger there, and the cocaine itself is making the situation worse by compromising what our cardiac system's capable of doing.
Okay, and I think these just keep going. So we'll see. This other one is about this section of your talk too. With the stimulant psychosis that is a side effect of the addiction, how is that different from the genuine mental psychosis? And is there anything the assessment specialist can specifically look for?
It's not very much different when you're talking clinical presentation, because the stimulant psychosis is kind of like a false impression. We've got neurochemicals in our, the levels are now reflecting, or they are at a position where someone is going to appear to be psychotic, and their symptoms may be interpreted as being psychotic, but it is because of the effects of the drug. We really condition the brain to react in a manner similar to someone who is truly diagnosed as psychotic. As far as an assessor being able to identify something there and do something about it, again, I think you need to look at historically what the individual is bringing to you, and then again, what the time frame is relevant to their drug use. If it's a situation where they haven't used stimulants and that can be kind of confirmed for a number of days or even weeks, and they're still presenting as, you know, this psychotic episode, there may be more to it than just a symptom of the chronic use. Again, it could be a condition where it has led to a chronic state where now we're not quite sure if this person is truly psychotic or just suffering from chronic effects of stimulant abuse, or maybe a little bit of both. So if it's something that is going to deserve enough attention, I would refer that person to someone who can truly make that assessment via a psychiatrist or that type of an office. I think in an evaluation for drug and alcohol treatment, it would be well noted of what we're seeing, and that the possibility exists or that we've observed some psychotic behaviors, and you could describe it, and without the benefit of knowing a history or seeing no history of psychotic treatment, this may be the initial stages of something, or we've noted that they've been smoking crack, or we've seen a stimulant use history. Perhaps it could be a case of severe stimulant psychosis, and I think that will lay the groundwork for further evaluation on what this patient needs. Certainly, if it's something that's presenting clinically in an evaluation, that's something that's going to determine their placement, I would think, pretty quickly.
Okay. There is a question about methamphetamine, but we'll hold that until after your next session. Your next section, because you might answer it during that. This other one, I don't know if you want to address now or not, too. I want to know why bath salts are so important with the young generation. Do you want to address that now or later in the presentation?
We could address it now. I mean, important, is that how the question was asked? Why is it so important?
Why are they so popular with the young generation?
That's a good question. I mean, I think that gets to what we're dealing with anymore. I mean, you get something that's new and severe and can really push the envelope, and I think that's kind of where we go nowadays. We push the severe. We got we've got adolescents and young adults that, cocaine doesn't do that anymore. The hallucinogens that are of old don't supply that. And if you knew the caffeinone structure and looked at it as a chemical and what it does, and that it really, really supplies a bang of dopamine and norepinephrine, where it's almost like a stimulant / hallucinatory drug. So a high dose of that is really going to put someone over the edge, and popularity with it might just be a reflection as to, how can we go the extra distance nowadays? It's not enough to just get so high that we need this. I mean, I'm surprised of the popularity of heroin among that age group. It's not enough to get a slight kind of manageable high anymore. It's got to be, a true blowout high, and more young people are attracted to that type of a recreational drug. So maybe bath salts and the caffeinone, which is the chemical in it, provides that recreational activity that's more reflective of what young adults are looking for nowadays. And that's really